Hello. Can you guys hear me?
Yes.
Oh, great. All right. So let me just wait for 1 minute more. Yeah, I think many people are still attending.
So it seems like everybody's on mute, so.
Shane, should we take like a 3-minute break and come back at 12:07?
Yeah, sure. Yeah, you grab water, coffee, tea, whatever you want. I know it's a long session, like a 3-hour conference.
Okay.
We have a pretty small group.
That's good. So we can have a more insightful discussions. All right, I think it's a time to kick off.
Sure.
Yeah, so we have 10 participants, and this session will be hosted by me and Forough. All right, so let me have a quick introduction to myself. I'm a trained computer scientist in the field like machine learning, signal processing, computer vision. I began my career at Harvard Medical School as a research scientist and instructor. And then I served as a consultant to biotech companies and startups. Now I'm a data scientist director at Novartis AI Center. Yeah, Forough, yeah, please introduce yourself.
Yeah, hi, I'm Forough Ghahramani, Associate Vice President for Research at NJ Edge. NJ Edge is a regional research and education network, and my background is high performance computing. I work with the research community in the region to identify their research computing needs. I have experience in industry and academia. An area of focus has been bioinformatics for me in some of the research areas that I've focused in.
All right, great. So this section, we are going to discuss the technology and the policy about the connected healthcare. And we have 4 main topics to discuss. And the first one is try to identify and discuss the challenges. And so before we start the discussion, just have a brief like introduction to the connected healthcare. I think Dr. Julian already mentioned that during the keynote speech. However, I think the technology is advanced in the past few years. We have more computing and more capability to do much more things. While all the devices are connected to each other, we can even organize the remote or telemedicine, for example. Even we can convert every single device, be like a health related device, for example, in your iPhone or your smartphone. They have the monitoring capability, they have a listening mode to your heartbeat, for example, or monitoring your glucose or whatever. Or the smart speaker, they can kind of talk to you and try to analyze your voice signals. And of course, in the hospitals, we have more and more devices at the bedside. In the traditional connected healthcare device would be like a vital sign monitoring device, or just a single ring bell. Like the patients can ring the bell and then the sound will propagate to the nurse, who in turn will go back to the patient to take a look. However, now we have a more sophisticated, complicated devices. All right, so when we have this kind of advance in technology, and all the devices are connected to each other, what kind of policy we need to keep in mind? Because technology has no limit, but without the appropriate regulation, sometimes something will be inappropriate. For example, the patient's privacy, when the device is monitoring your vital sign. And we don't want to have a hacker to jump in to listen to that, or the data in some devices go in the server will be leaked out. And of course, we need to have a regulation on that. And even beyond that, we also have many different aspects. For example, the connection, communication, should the internet provider be neutral, net neutral, or they need to have a limited bandwidth for the healthcare, or the guaranteed bandwidth for the healthcare provider or the healthcare devices. And in terms of paying, I know for the healthcare providing, it's a very expensive process. And should we have a regular or systematic paying system? So all of this not only just cover the technology, but the policies. So, the first topic, we just want to identify some challenges and the risks that the technology and the policy we should consider. Yeah, so I'll open for any person, feel free to jump in and raise your hands or just voice up your ideas. Then we can have a discussion from there.
So this is Jim. So Shane, is the question policy that you're asking, or is it, because I come from an infrastructure perspective, right? Mm-hmm. So think of your house. Mm-hmm. You own the house and you decide what you're going to put in the house. If I invite you to my house, there's certain conditions. You're going to come to my house. You won't break things. You won't do anything. And that all the data in that house is pretty much controlled by the infrastructure that surrounds it, right?
Yeah.
So in that simple model, simplistic, of course, everyone has access to the data. Everyone has access to all the devices that are in there, but everyone has to conform to the infrastructure that I have within my house.
Mm-hmm.
Yeah, so I think there are so many different use cases, right? For example, you have a telemedicine, which requires the connected device in the patient side and also the care provider side. That could be, maybe it's my home in the hospital, could be a local hospital, mm-hmm. Could be remote to 2 states in the country, or even across the country, like Ebola case that Dr. Julian just mentioned. One patient could be in Africa and one physician could be in US or in Europe. Yeah, so I think we can mention that what kind of use case you want to address, and then what kind of policy will be there. And in the telemedicine case, of course, we want to have a strong bandwidth, right? I mean, we don't want to have an internet provider limit the bandwidth. Otherwise, we cannot really deliver the healthcare smoothly. But this kind of issue is not really just involving 2 parties between the healthcare provider and the internet provider. I think the government, or from the from the government perspective, they should set out some reasonable limitation. When you have for example, a remote surgery, or your bandwidth should not be less than some gigabytes, for example. Otherwise, you will have a latency, and then this healthcare delivery will be screwed up, and the patient life will be.
Could I suggest that we start with just listing some of the challenges that are there, and then listing some policy considerations, because the next question is, where are the gaps? Where, so we just start with some of the challenges. Like, one of the challenges is interoperability. Another challenge is balancing the user experience, having the user experience be seamless with data safety. And so, if we could just list some of the challenges that exist.
Well, I'll throw in infrastructure, because many of our clients are deciding if they want to go to the cloud. Do they do a public cloud or a private cloud, right? Very simple, right? So to your point of safety and protecting the data and those types of things, our hospitals in that position to do that. We also have hospitals that are providing remote care. So what's the connectivity between the hospital to the remote rural area where they're monitoring patients, heart rates, let's say, that type of thing. We have clients that do that. That's what they do. So I think infrastructure to me is like the big thing. What kinds of infrastructures are out there? Which ones are permissible? Which ones do we want hospitals to have? That type of thing as a starting point.
Yeah, that's a great point.
Can you hear me? This is Jorge, and I'm sorry I joined late. I work at the VA, and I come at this from a very clinical perspective, informatically speaking as well, because I work in the operating room. And one of the things, as Dr. Ghahramani, he's an anesthesiology by trade, so when he's talking about interoperability, you have this multitude of medical devices that are providing data in the acuity of the instance of care that you're delivering. And so, for example, I work in transplants, liver transplants, and it's very common during a liver transplant that the data flow, and I'm talking about physical data flow. We're doing a transplant. We have monitors in front of us that we're actually physically looking at the parameters of the physiology of the actual transplanted patient. And so the data flow and interoperability there is very, very discrete, is very selective, and it has a timeliness of instance, meaning what's important in 1 to 2 minutes could be irrelevant in 30 minutes, right? Because the physiology of that patient has changed so dramatically because their blood volume has shifted when you're putting the liver in. So you have a completely different individual now that you're operating than you started. Well, that dynamic is played out in a much smaller scale in most of all these high acuity instances that Dr. Ghahramani was speaking about. So when you speak about interoperability, we have to understand that the data, quote, liquidity of the interoperability is weighted based upon the clinical representation in that moment in time where a clinician has to make a decision, life-rendering decision. But then you have to couple that with what Forough was mentioning with regards to the usability. So if I'm in the operating theater and all of us are very familiar with the monitor and the data and the illustration and the representation of the data, because we are, that's our world, that's what we see every day, so we're very accustomed to that. But what happens when you telemonitor or teleremote that data instance or experience to another clinician who doesn't have the same view and experience that we have as a team? All of a sudden, you've changed the user interface, the data is represented in a different format or a different way that they're used to. Then you start getting into that problem of what oftentimes people call disposable UX. What's humanly usable for me may not be humanly visible to another remote team in the instance of care. So I think interoperability and usability are, without a doubt, probably the most difficult aspects technologically, infrastructure to have to deal with. And if you don't have a good grasp, and I would say try to start really, really small, in a very small, discrete example, as opposed to, I think it was Shane was talking about telesurgery. I was at Hopkins, so they were trying to do telesurgery 20 years ago in transcontinental. They had a latency and the patient was bleeding and they couldn't stop the bleeding because of the latency, because of, when you hit the Bovie machine, there was transference latency from device to the individual holding, the device in the operating theater in the other country. So of course, that's infrastructure, right? As Jim was alluding to. So, but I think now with 5G and more enabling capacities, you're beginning to shorten the distance, but it's not about the shortening of the distance. That's the only problem. You have also problems of local transmittal of the data itself. So I think if we can look at it from that perspective, we might be able to, bring some value to the other teams.
So Jorge, would you say that the data needs to be tiered? And by that, I drew down on my notebook. You're very close to the patient. You see the information. Let's just, for argument's sake, let's say you're seeing it in milliseconds, right? It's continuous. It's constant. You're making immediate healthcare decisions. Then there's the next ring around that, which is to take it and put it into seconds, right? Or maybe every 10 seconds. You want to store that. You want to put that information together. And then for whatever reason, we may need to have a summary of that data, and maybe that's in minutes. I'm not looking at making a decision on the minute side because you're already looking at it at the millisecond side. So it's almost like a donut or concentric rings where the data becomes the focal point, right? You need to do it for the patient, but maybe Shane needs to look at it on an average, for instance, and he's not interested in milliseconds because that's overwhelming, right? I'm going to have to do something with that data.
Yeah. I think that depends on the application, right?
Yeah, but I don't know if, and maybe I'm wrong, I don't know if any systems are dealing with data that way, right? Maybe they are. I don't know. To the point of interoperability, because all that information needs to be summarized and put in a patient's healthcare record, right? He's going to have some kind of a, I kind of look at it as a picture.
Correct.
He's got to have that in there.
Jim, but the example you're bringing, Jim, is a beautiful one. And let me just expand on that. If I gave all the millisecond data that we process clinically during the transplant to the next provider in the ICU, they would be absolutely overwhelmed. They only want to see what you just alluded to. If you're the receiving intensivist, when we transfer the patient, you almost want what happened in the last 8 hours. And you have 2 minutes to tell that story. And then that's on the one extreme. And then you have everything in between. The critical care nurses want to know those snippets of every hour. What happened in the OR every hour, the last 8 hours. And so what I call that data acuity, meaning the acuity is meaning the criticality of the patient, meaning of the data. There are some things, and if you don't have a flux flow, meaning how much information you need to know in that instance of care, it's not just a volumetric data point, but it's also, you don't want other data to sort of get in the way, if you will, because the overwhelming of the data processing, human beings can only process so much in the instance of care. And if you're looking at an aorta with 2 cross clamps, you want to be looking at the aorta. You don't want to be looking at screens and doing, why? Because, hey, stay focused. Well, yeah, I know, but you want me to look at the data. The hell with the data. I need you to cross clamp the clamp. And so all that acuity needs to be considered, because as you're processing the data life is in, you literally are holding someone's life in your hands.
Yeah.
And so it's that beautiful balance, Jim, that you just articulated.
Shane, you got that?
I posted the link to this document that we're trying to keep up to date based on the comments that are being made. Please feel free to add as we go and modify.
For some reason I don't get access to it, but let's deal with that later. That's okay. That's fine. Yeah, don't worry about it. I sent you a request. We'll do it later. Okay.
Yeah, I don't.
And it's just the way my computer's set up. That's all. No big deal.
Okay.
Oh, hi everybody. Sorry, I joined a little late and I don't think I have a link to this. Is there perhaps I wasn't in the chat earlier.
Yeah,
so far data acuity was one with and now we talked about infrastructure, right? Was the other one?
Did I capture the information about data acuity?
Data acuity.
No, it's like acute care, so it's acuity, ACUITY.
Right. No.
And by that, the concept that you want to be able to articulate is that data has call it a weighted ratio, meaning is the data important during the next 60 seconds, or is it important to me only during the next 5 seconds, 10, 15 increments? So the data acuity in the instance of care is that don't treat all data as all of it being important at the same time, or there's certain instances of the acuity of the patient, meaning the state, the physiological parameters of the patient, where the data may be more or less relevant depending upon the clinical presentation, meaning the acuity. And so I look at data as just a physiological representation of the state of that individual. So that's where that concept of data acuity comes in. If we don't understand that, then everybody says, "Oh, give me all the data." I don't want all the data. I want what's the most important data for that instant and moment to make a clinical decision on the relevancy at task. Because if not, then you're dumping a lot of bad data, massaging it, trying to pretty it up to make it good data. And that's no. If you would have given me the one point that I asked you, perfectly executed with fidelity, I don't need the other 10 that are useless that I don't want to see.
Yeah. So would predictive analytics come in at any point here?
It would, in the sense, for example, and I hate to go so physiologically on these examples though, but an example that I was giving to you about a liver transplant, if you know that every 2 hours, right when you're about to put the liver in, you always have to have these elements available to the team, then the predictive analytic is that you must be able to present those data elements on each instance when you're about to now sew the liver into the vena cava. And why? Because that's technically what everybody has to do. Now, you may say, well, where does predictive analytics come in? Well, it comes in because clinically, every instance where that scenario is presented to optimize the decision making, the clinical team should always know A, B, C, and D. Why is it predictive? Because if you don't have that data to present, then we get into these little mini black holes, right? Where we're guessing, we don't know you're hoping that you have somebody with a lot of gray hair in the room, with a lot of experience. And if the guy across the table has dark hair and doesn't have any gray hair, you start sweating because they don't have, that. So now what happens? I tell people, what happens if the case is going great and it turns into a horribly difficult, challenging case? you want the most experience now in the room. Well, what's the difference between I want you to get that man or woman in the corner with gray hair in the room and predictive analytics? If predictive analytics can, I tell people, I want to know what he knows, what the old man knows, because when he comes in, he utters a few things and he gets the whole room kind of in the right state of being. Why? Because his experience is between his ears, right? His predictive analytics is basically his brain. So think about it from a computational perspective in this scenario. Yeah. How do you bring the experienced clinician that may not have great hands, but he's got all the knowledge, and then you've got the young surgeon with great hands but no experience? How do you broker that difference?
I mean, may I give an idea on that? Why just do a Zoom or video conference during the operation, and you have a gray hair person maybe 10 miles away, and he gives you the advice you're looking for. Technology is there.
Yeah.
So advice for next step.
And in terms of kind of the course of the discussion here, I just wonder, I mean, it's all about the technology and maybe policy considerations, how things are operable and interoperable. I mean, I would have one question to Tim, actually, as he's with T-Systems, I see. Are there from operators specific services offered to hospitals, for example, to provide, let's say, constant bitrate streams of data or connections like you have in autonomous driving in the future?
So what comes to mind, it's a good question. What comes to mind are two things. So to answer your question, when I was talking to Shane about the house and the connectivity, public versus private, you offer the service like you would any kind of cell phone, and you get a certain rate, right, of data that goes back and forth. Now Jörg is talking inside the operating room, and maybe I'm the gray-haired guy looking to call in to give some advice. So the infrastructure has to give you that capability that's secure and all that sort of good stuff. Yeah. Outside the United States, most of the state-run healthcare facilities are pretty much controlled, right? In other words, they have their own network, if you will, of hospitals. In the United States, we have it's wide open. Each hospital operates differently. That's why I'm stuck on infrastructure, because Shane, if we were to say to everybody, let's have a blue infrastructure, right? Everybody goes to the blue infrastructure. Then they all say, oh, okay, I got this target I have to go towards. I don't know what that target is. That's one thing. And then to answer Jörg's question and Anton's question, it's a matter of, I'm going to serve the data up. Forough is going to do some analytics behind it. And I want that private connection into that operating room where everybody has all the data they need, right? And I can give advice with one set of data and another set of data. I'm looking to make an instantaneous medical decision. Does that make sense? Does that make sense? Because we talk about a couple of different things here, and I'm taking notes then, even though somehow I got to email it to somebody or whatever. Kind of get this in there. Infrastructure and data acuity are the two ones that come up. Connectivity is the big thing, right? 5G, but we can't wait for 5G. This stuff we have to do now. So
I mean, you can do it now already with 4G.
Yeah, exactly. 4G. Yeah.
We have enough data bandwidth, at least. Well, maybe not everywhere, but let's say, I think the guy who presented before that session, he had this map with the hospitals across the United States.
Yeah.
I mean, there are gray areas. There are no hospitals. There are probably also the same areas without any wireless or any other network connectivity at all.
Exactly. They're going to get balloons with internet connections. That's what they're going to get. Yeah, absolutely. So is there something else? Because the other topic I was going to share with you is the IoT device, because that's what we're focused on. And the reason we would look at that is to gather up all the data inside a given room, right? So almost like a concentrator. We were talking about remote devices and looking at different things that are going to try to pull together. So people are working on hubs, right, where I can take all the devices and make one connection outside of the room and then be able to do that. But it depends on the infrastructure. But I'll put that away for now. That device, that people are out working on those devices to gather all that up. So is that a secure link? Is that something that we could do to kind of overcome that problem of everybody has different devices, the blue ones, green ones, pink ones, and they're all in the room, and Jörg's got to figure that all out because he's trying to treat the patient. He's got all his data coming at him from different devices. Does that make sense?
Jim, the IoT, are you talking about intra-hospital based IoT devices? I assume that your example is that correct?
It could be. We've been looking at things like between hospital facilities, tracking things, and then inside of a hospital, just looking at like inside of a room, right? Because we were talking about ICUs where you can't walk in there, but there's 12 devices in there and they're all not from the same manufacturer. They're all FDA approved and they're all collecting data all over the place. So how do I rope all of that together? How do I pull it so that the clinician outside the room can make a decision, right? Because he wants all this information.
We're beginning to see, which is something that, because right now, as I'm sure everybody on this phone call knows, there's almost very little of that data that is interoperable or interface, within a platform. Is that the individual, they're enabling the clinical individuals now to have these voice-enabled devices, Vocera as an example. So now you got the clinical personnel wearing this little gadget, and this little gadget is basically a voice-enabled communication platform to do all that data brokering that I spoke about, because the timeliness of the data that needs to be not documented, but expressed in between clinicians, so clinician to clinician to clinician. And so I ask, every time I see a nurse or somebody with this Vocera hanging on their neck, I ask, does that make you a better clinician? Are you better at doing what you do? And, they chuckle nervously at first and they say, well, it's just another damn gadget, but it does allow them to audio archive all the communications to do proxy calling so that they can better monitor the communication of these high acuity data exchanges between these personnel. And so why are they doing that? Because they don't have the infrastructure that you folks are speaking about. So they've gone to a lower tier technological solution that I almost call it a little bit of a hybrid, meaning you don't quite have what you need, but you have better than just a paper form attached to Jorge's forehead, walking from a room to a room, which is, oftentimes what people used to have in the old days. So I think it's, there's this whole sort of concept of technology enablement. Are we in a place of maturity where the technology can enable current state? And if not, what do we need to do from a policy perspective? And if so, why isn't everybody using it? Because that's the other argument that we always have in the operating rooms is, if this is so great, why are people hating their lives? Or why aren't you making them better clinicians? Because in an operating room, if I have 6 different tools to cut the abdomen, I choose the one that's going to make me the best performer. Technology is the same way. You have to offer a technological solution to a clinical individual if you're going to affect their work that's going to optimize their human capacity to perform. If not, why are you asking them to use the little widget or the little gadget?
So is the question, let's assume maybe Anton, Jörg, and anybody else, if we were to put 10 devices on the table and we say, pick the best one, right? That gives us X, X, and X, right? Gives us the data, easy to use, ultimately can make the clinician a little bit better. Is that something we want to strive for? because everybody's making things. I mean, I'm sure Todd and Michael and maybe Carlos has ideas for different devices that are out there, and maybe that's a question to ask.
If we take that example of a surgery room and you have 10 different IoT devices in that, I mean, for me, the first question is it all from the same supplier, like GE or Medtronic or whoever, Philips, the key players in it? And if yes, then my understanding is that they offer in also software platforms on the system, so they can display data from each IoT device in a certain way, that it works according to the needs, like George has, or maybe another person has in that room. You can even select probably what you want to see. If everybody has maybe his own monitor, the anesthetist has its own monitor, he can see what he wants to see, and the other guy sees something else. The data is transmitted at the same time, and you just select what you want. If it's from different suppliers, well, then how do you enable the interoperability? Then you more or less, the hospital itself could say, I have certain rules. I have my main software somewhere in a server sitting. I need to communicate with those devices, and the communication usually goes via Ethernet, or on an IoT device, it's usually Wi-Fi, or maybe, well, another radio standard that is applicable for that hospital. But it's one thing. It's the same radio standard. Then you need authentication maybe of the devices. Are they an authorized IoT system? Or maybe a nurse brings in a device from the job she did before, and it's not operating well, and maybe creating issues with the existing system in the surgery room. So the IoT device has to be identified, authenticated, authorized to work in a certain environment. I think that's another important thing.
So Anton, you raise a very good question. So what is that environment look like?
Yeah.
Right? Oh crap. Sorry about that.
It differs from use case to use case.
Sorry about that. So is that that environment that you talked about, is there a standard around that? Is there something that, Shane, we could say every hospital has to go to blue, and they're going to have to follow standard XXX? Because in Anton's example, you know, maybe Carlos wants to bring in his own device because that's what he's familiar with, and he wants to put it in the network.
I think now is the kind of the point. Sorry, I need to kind of interrupt and pause a little bit here. Yeah, because we already identified many key challenges, and then Jimmy also raised the question of how we mitigate. So I think now is the good moment to kind of switch the gear a little bit. Yeah, so among these questions and the challenges, how we can propose some solutions, maybe not immediately available, but what would be the potential pathway toward the solution? Just like Jim, you mentioned, oh, okay, so we have this kind of issue, but in this kind of case, in that kind of case, in this environment, in that environment, and how we can do and make the whole connected device operate better. Yeah. So yeah, feel free to jump in and then provide more thoughts, but I just want to gear a little bit toward the possible solutions and our recommendations.
Yeah.
I think one issue certainly is that, for example, one of these big suppliers like GE, Medtronic, or Philips, that they probably don't even have any interest in following some standards, because if they do that, the hospital can go and acquire some nice gadgets from the other guy. So if they have a proprietary interface and software provided, they close out the other guys immediately if they got a win of a certain hospital's tender of equipment. So
Yeah,
it's something the hospital need to address, and
Mhm.
But isn't that the focus of the IEEE standard, and is to come up with something that says, okay, you're GE, you're Medtronic, and if we go to the standard, we just do a software upgrade. It should be that simple to say, you know, we'll all speak, you know, it's kind of like we'll all speak English, for example, so that we can make the interoperability easier to kind of do that. And that's a simplistic example, but it is probably going to have more challenges, more complexity, so that we go back to that data analysis that we had in the beginning.
Mm-hmm.
I mean, having a standard is always good, but even if you think about Wi-Fi or BLE or even Ethernet, if you finally implement it, the standard is defined in a certain way, but the devil is in implementation.
Yeah.
If you do a system and you have this interoperability sessions, then that you try to get your IoT device work with smartphones from Google, from Apple, whatever.
Yeah.
It has to be tested if it really works, because the overall standard is all what they follow, but the devil is in the detail.
Okay.
It's just like what happened with the computer industry years ago, is that you know, the proprietary, and then going more to open, and there was that constant clash. And I think this is what's happening with instrumentation and the communication between the various devices at this time.
And then sometimes even the guy with the biggest market share just defines what the standard is.
Yeah, let me not to throw cold water at the argument, but this is a perfect example of one I saw on the weekend. We have a new perfusion system that's for the transplant. So the perfusionist walks in with their machine, their software, their application, their documentation, their interface. When I spoke to them, I said, oh, you know, because I always pay attention. I said, you have a small machine. And I asked him, does that interface to Epic? Because that's, you know, and he absolutely almost, you know, threw me out of the room. There's no way in hell they have any interest in interfacing the transfusion pumps to Epic, because their proprietary data on the pump is that's their gold mine, right? So any time that they quote unquote now, you know, release or allow them to see their transfusion metrics, then they lose market intelligence, if you will. And so I think it's important, because we're in that point in the conversation, that we should try, at least from a policy perspective, is determine which areas, clinical use case areas, do we really need to have this type of one/platform, cross-platform agnosticity from a technical perspective, and which ones do we not care? Because if we don't, it's not all or none. There's some areas where if you don't have that, people's, you know, lives are in harm's way. But then there's many areas where you can go about your own business, stay in your little silos. Nobody's dying and everybody's doing quite well. And so we need to have a way to kind of filter out which area must we absolutely have this quote unquote full stack integration, because it's absolutely critical for the provision of care, safe care. And in which areas do we want a little bit of in between? In which areas do we not need that because it's really not needed? Because I think it's important that we walk into the areas where this is happening, but when you really see what people are doing, by and large, almost all of these proprietary medical device systems have these incredible data entry, data processing interfaces, but they keep it to themselves. You know, make no mistake. Even if I ask the CIO of my hospital to give me the data from the transfusionist, you know, software vendor who's a contractor to our hospital, they would tell me to, fly a kite. But that's never, ever going to happen. And so that's one of the, I think, concerns that people need to be aware of, that, everybody says, well, we need to work together and, go to a concert and drink good wine and have beautiful food. Yeah, but not everybody likes, the beautiful food, because the beautiful food might be taking, competition from the other vendor. These vendors are extremely competitive in these high acuity areas. I mean, their whole competition is dependent on the control of the data. And unless we talk about that issue and what's the proper balance of data, then we're going to continue to have this conversation for the next 10, 20, 30 years. I've been having this conversation for at least 25 years in my professional career.
Yeah, I think you raised a very good point. Yeah, we need to kind of see what we need to focus on, in which use cases we need to focus on. And I'm just wondering, based on your experience, George, so from a policy perspective, will that focus on just have a manufacturers talking to each other, or we will have some government agents need to enforce something? Yeah, because that'll be totally different. If you have a government jump in, and then that will be regularized, and then we'll have a more, I would say, standardized communication, computing environment, or whatever, to facilitate this connected healthcare providing.
Well,
so Shane.
Go back to the history though. If you go to in the government, when did the government first begin to focus on standards in health informatics? It was in 2004 when President Bush told us at the federal agencies to put up this little federal consortium called Consolidated Health Informatics. We all agreed on the standards. All the standards were there. And 15 years later, very few, if any, have ever been adopted. So even when the government policymakers came up with, quote unquote, the standards, and just look up Consolidated Health Informatics, White House, informatics, and you're going to see all the standards there. Even when the government stepped in and funded projects to go this route, the vendors still, they said, it's when I'm ready to integrate this in my system, I will do it. Not a minute earlier, not a minute too late. So there's this dissonance between how forceful can a government be, or a policymaker, or the Office of the National Coordinator, because standards, we've been pushing standards for almost 30 years, yet we're still not interoperable. So that begs the question, do we continue down the same road of standard pounding on top of our heads, or do we come up with a much more sort of novel, creative way to get to the same desired interoperability state without having to go through the same either policy funding or market, quote unquote, collaboratives that yielded very little in this space? What is very clear is that we have to come up with new paradigms, because almost nothing is working the way we intended it to. So, I'm open for any and all discussion. Why? Because, for those of us who've been at this for a long time, we've tried just about everything, but I call it the interoperability white ghost, because it's like this white ghost that everybody talks about. Forget about the white elephant in the room. It's a freaking ghost. It's like, if you saw interoperability, would you invite it? Would you hit it in the back? What would you do? What does that really mean? And to me, God, I hope you're not giving me attribution to all that you documented, because but that's okay. But I think it's important. Interoperability is still an extremely elusive concept because of the gradient of variability of the definition of what it is to be interoperable. When you talk to a federal agency, oh yeah, we're interoperable. No, you're not.
No.
All the stuff that you're exchanging is almost non-computational. And so it really, we need to get to a much better state of definition before we try to, make a little bit of an inroad into the space.
I'll just raise this point. I know, because I work on another FDA standard, which has been going on since 2013, and maybe we'll get to it by 2023. That's the hope, that's the goal, like this. But Epic refused to follow the interoperable standards, which would make data between electronic health records easily accessible. And so that's the big sticking point. Industry can say, we don't want to do that. But at the same time, it does require the US government, the way we typically will do it, is put a guideline in place and then force everyone to say, we're going to have a law that's you're going to abide by it. And you give plenty of people runway to get to that point. That's all. It can be done, but it's just attrition, right? IEEE standards are there because we have to get to some point of, all Wi-Fi will behave the same. And here's a standard for Wi-Fi. All cell phones will behave the same. We do have to get to that point, or else the only other way to do it is all of us come up with a device design that does everything for everybody. And then hopefully we make lots of money that way. Then,
I know one thing's based on market
technology in the room.
Yeah. By the way, I think the meeting room will close in 5 minutes, so we need to kind of wrap up a little bit here. Yeah.
Jane?
Looks like from a technology point of view, it's an easy thing. But getting to agreements, how things should be interoperable, in what region, in what use case, that's the difficult thing.
Yeah, I think one thing is based on the enforced policy. Another thing would be just have the freedom to do everything, and then let the market decide whoever will be the winning players. But I don't know. I think the patient's protection and the increase the better healthcare providing is a goal. So we hope we can have all the agreeable vendors and the nice vendors players inside this industry to offer the better solutions.
Yeah, I think we should have an IEEE little snippet when whoever calls up, because as you should leverage the very kind of host that's having this call, because there's a reason why IEEE has been around for a long time, and so if we're kind of stuck, we should go to the IEEE gods and ask them, what do you guys normally do when you have an incalcitrant industry that is, basically, Jim, that was a perfect example with what Epic did with the open APIs. Basically, and that was many years ago, they basically paralyzed like millions of dollars, billions of dollars of work by saying, we're not going to engage in that. Yeah. And it's basically, we've lost like 8 years because of that.
Okay, I think we only have 3 more minutes. Shane, how would you like to do the report out? Do you want to take one section and I take the other? One of us do the challenges and one of us.
Oh yeah, sure.
Hey, how can I get these notes to you to help you?
Oh, you have notes?
Of course. I've been, I'm not being, I wasn't being rude and not paying attention, but I was.
Thank you so much.
At the same time. So I captured all this stuff for you. So give me an email, give me something, and I'll get it to you in 2 seconds. Just cut and paste and go.
I'll put it in the chat.
All right.
That would be great. Thank you so much.
Oh, no, absolutely. Happy to help. And hopefully you'll understand my points.
Thank you. Sorry about the connectivity. I'm not sure as far as having access to these documents.
It's Google's Docs. What are you going to do?
Yeah, we are. That's kind of policy technology as well. All right, so how about this? Forough, I will let you to summarize the first part, like challenges and risks, and then I will summarize the second part.
Okay, sounds good.
Yeah, thank you for everybody's comments and the insightful ideas. Yeah, so anything you want to wrap up here on the attendees? Because the room will be automatically closed, so without any.
Okay, let me know if you've received it.
I got it. Thank you.
Oh, you're welcome. You're very welcome. And nice meeting all of you, by the way.
Yeah, likewise.
And
I
Todd,
always feel bad.
yeah, Todd,
Great.
tell me who that dog is. Come
Oh,
on.
thank you.
Yeah, nobody ever wants to see my photo. They're always just like, well, I just want to see the dog. So yeah, it's like, oh, I got this guy. Great, put the dog back on. So yeah.
Okay.
I gotta get a dog.
All right. Okay, I guess we'll leave this session. Okay, we'll see you later.
Yeah. All right. 30
Thank you
seconds.
all.
Yeah.